We've taken this opportunity to speak to as many of you as we can tonight about nausea and vomiting during pregnancy. You all know that these are extremely common symptoms, and women have been expected to tolerate significant symptoms, both physical and psychological, because it's normal and an expected part of pregnancy. For women with mild symptoms, it may be considered physiological, but for a small number of women, specialised care is required. As clinicians with a special interest in nausea and vomiting of pregnancy and hyperemesis gravidarum, and I hope you'll allow us to say NVP and HG for the evening, we recognise this is a poorly managed aspect of pregnancy care for a number of reasons. There is reticence and scepticism on the part of the women themselves, and there's fear on the part of the caregivers, particularly about the use of medications in the first trimester, especially after the thalidomide tragedy of the 1950s and 60s. We recognise that management needs to be appropriate for the degree of impairment. It needs to be safe and timely, with an emphasis on ambulatory rather than inpatient care. At the same time, we want to ensure that all the normal aspects of antenatal care are maintained. In the guideline, which will be published on the SAMAN's website in the next few months, and hopefully in a famous and important journal in Australia in October, we include a strong emphasis on individualised management plans, good communication with all caregivers, and both the physical and mental health of the women. We also recommend a protocolised approach, individualised for your resource setting, to determine the best person and the best place to provide care for the small number of women with severe NVP and HG. Tonight we're going to briefly present an approach to NVP and HG based on a careful review of the available literature and awareness of the enormous impact these conditions have on women, their families and society. And I thought I'd start with a typical scenario for one of my patients and probably for one of your patients. This is Mrs. JC. She's in her second pregnancy. Her last pregnancy was 3 years ago, and in that pregnancy she had to give up work until 20 weeks because of NVP. She spent most of her time at her parents' house in bed. She lost 10 kilos from a starting weight of 64 kilos. She was induced at 37 weeks, really because of patient distress, not fetal distress, and ongoing nausea with occasional vomiting. She delivered a male infant weighing 3.1 kilos and unfortunately was unable to breastfeed. She presents with her partner at 7 weeks, already very nauseated. She's vomiting 6 to 10 times per day. She has poor oral intake. She's desperate. She's been given metoclopramide 10 milligrams TDS, and she asks for our help. So I suspect for many of you that's a story you hear infrequently, but very importantly, and it's almost one of those heart sink moments. Can I do something for this woman? So to start with an approach to this sort of patient, this guideline very specifically defines NVP and HG. So NVP is nausea, vomiting and or dry retching caused by pregnancy with symptoms commencing in the first trimester without an alternate diagnosis. And we are rating severity based on the PUQE score, the Mother Risk Pregnancy Unique Quantification Score of emesis and nausea, which is a validated scoring system for severity. The PUQE score correlates with severity and a woman's own estimate of her physical and mental well-being. In practice, the 3 questions that are asked are related to the number of hours of nausea, the number of times they've vomited, and the number of times they've dry retched. But we all know that there are women who may have a low burden of vomiting and dry retching, but have such profound nausea that they're unable to maintain oral intake because of nausea and or food aversion. And of course, those women need to be managed very carefully as well. And you need to ask about these symptoms up to about 14 or 16 weeks, because women themselves will often accept a high burden of symptoms without mentioning them, just assuming that they're physiological. So with this scoring system, the minimum score is 3, and a mild severity is a PUQ score of 4 to 6, a moderate severity 7 to 12, and severe is greater than or equal to 13. Hyperemesis is defined as nausea and or vomiting caused by pregnancy leading to a significant reduction of oral intake, dehydration, electrolyte abnormalities, and weight loss of at least 5% of pre-pregnancy weight. By definition, this condition is considered severe. In particular, it does not require the presence of ketonuria, because a systematic review and meta-analysis found that there was poor correlation between the presence of ketonuria and either the diagnosis or the severity of HG. But of course, we don't want to wait for this sort of weight loss or impairment of nutrition to instigate aggressive management of severe NVP. But it is important to recognise the two levels of severity. So what is the cause of NVP and HCG? It's unclear. What has become a feature is that there is a strong genetic predisposition, and heritability estimates of up to 73% for the occurrence of HG and 51% for the duration and 53% for the severity have been identified. And there's a large consortium examining this carefully. It probably won't alter management, but it's perhaps the old wives' tale of my mother had it and I'm going to get it is probably correct. There are inconsistent associations with work status, income and education levels, and there is an association with the female fetus with an increased incidence. So what investigations are required for women with NVP? And in this part of the guideline, we were trying very hard to minimise investigations because in general, they don't alter management. So women with mild to moderate NVP, a puke score of 12 or under, do not need investigation unless there is some other indicator in the history. They do need a good history and a physical examination. They do need to be considered for an alternative diagnosis, and I'll talk about those in the next slide. And they do need to be assessed for dehydration and malnutrition. If this puke score is greater than or equal to 13, which is consistent with severe, or there is suspected HG, then we recommend doing sodium, potassium, chloride, bicarbonate, magnesium, urea, creatinine, liver function tests, a TSH, and Amanda's going to speak much more about gestational hyperthyroxanemia in the context of HG later in the talk. And an obstetric ultrasound should be performed to rule out multiple gestations and gestational trophoblastic disease. And I also find it very helpful to date the scan, to date the pregnancy, because you can roughly estimate how much longer this patient has to suffer. Tests to exclude alternate diagnoses are done dependent on the history and examination. So we've included a long list of potential alternate diagnoses, all of which need to be considered in these women. The ones that are bold are the more common causes. Note the drugs, particularly the pregnancy vitamins, which the pregnancy multivitamins can certainly induce nausea and or vomiting in some women. It should be considered. But women with pre-existing gastroesophageal reflux disease, coexistent gastroenteritis, urinary tract infection, of course, particularly with pyelonephritis and migraine, all potential relatively common causes of nausea and vomiting that could be misdiagnosed as NVP or HG. The next question we addressed was who should be managing NVP and HG? And one would think it's obvious that clinicians with experience in recognising the signs and symptoms of HG and with expertise in managing this condition effectively. Now, depending on where you are, this might be, at least for mild to moderate cases, the community pharmacist, particularly in regional or rural areas. It may be a GP with or without an interest in obstetrics. It certainly should be obstetricians. It will often be an emergency physician, particularly at the first presentation, or it may be a midwife or a lead maternity carer. This is a Australian and New Zealand guideline, and the lead maternity carer is a very important part of the antenatal management in New Zealand. For more severe women or those requiring admission to hospital, we are recommending that a specialist look after these women, essentially an obstetrician, a physician, or a GP with an interest in the area. Due to resource availability, if there is no experienced clinician, we would strongly recommend finding an appropriate referral pathway to a larger or tertiary hospital, or engaging in telemedicine, and we hope that will be developed as a pathway, particularly in regional or smaller areas. And where should that management take place? And we're really talking about the women with severe NVP or HG. We still believe that these women are best managed in the community. There are a number of exceptions. Women that should be admitted to hospital, and we'll discuss this a little more later, but women with type 1 diabetes who aren't maintaining nutrition or fluids, other high-risk situations such as short bowel syndrome, women on essential medications, as for example, women with epilepsy or transplant recipients, they will all need to be admitted to hospital, at least for initial management, to make sure that they are under control before they continue outpatient management. And where that outpatient management takes place is also dependent on your resources. In our hospital, most of the care is taking place in our pregnancy day stay, but any ambulatory day stay facility would be suitable. If there's access to hospital in the home, that can be an excellent solution, particularly for women with other children or other caring responsibilities. This ambulatory care is a place to assess women and also to provide parenteral fluid resuscitation and or parental antiemetic administration if required in women who can't tolerate this orally in the community. The other options are the emergency department of the local hospital, but not the standard presentation with nausea and vomiting where you have to be triaged by a nurse, spend 2 hours waiting around, spend another 2 hours being assessed by a resident, then waiting another 2 hours for your treatment. That's really not the way to look after these women. It needs to be an expedited management within the emergency department based on a standardised protocol. Can be done in general practice or family practice or community health centres with suitable facilities. We're using private infusion centres here in our local area because they're available and accessible for some patients, or non-pregnancy day stay services depending on your availability. So just go back. I'm sorry. So being able to access outpatient services rather than requiring an inpatient admission is beneficial for minimising disruption and maintaining family units. There are randomised controlled trials of women given ambulatory daycare management with IV fluids and antiemetic therapy, which proved that it reduces admission to hospital and had high satisfaction rates for the women enrolled. And cost analysis shows that it's cost effective as well. In your setting, you'll need to decide, you need to set up a referral strategy or pathway for review. I've said physician review, but it could be an obstetrician or a GP. For example, after more than one presentation, I think they need specialist review in one of these places. And note that many of these women will be unbooked and therefore they'll need a pathway to get into your maternity service before they're actually booked for their antenatal care. The presentations will often be recurrent. In our pregnancy day stay, women are often seen 2 or 3 times a week for a period of 6, 8, 10 weeks. So we need to plan for how that can occur and what resources you have, where it's going to happen, who's going to be supervising the patient, and how they're going to be managed. So why treat NVP and HG at all? Principles of, and what is the best treatment for MVP and HG? And we're not trying to create a disease. We're not in the pharmacology, we're not in the pharmaceutical industry. There's no benefit to us to make this a disease. It's just a recognition that this is not always physiological and it does lead to harm. And we'll discuss the harm that it leads to later on. But when it comes to the best treatment for MVP and HG, there are a number of principles of management that must be included. These women require interventions, obviously, to reduce nausea, retching and vomiting, but they also need management of associated gastric dysmotility, that is their gastroesophageal reflux and constipation. They need maintenance of adequate hydration and electrolyte replacement, either orally or IV. They need maintenance of adequate nutrition, including provision of vitamin supplements where required. They need psychosocial support and assessment, and we need to prevent the side effects and adverse pregnancy and fetal outcomes of both the NVP and HG and our treatments. And then you need a number of considerations when you're making your treatment choices. The first one that I find very helpful is to establish targets for symptom relief. If your patient expects your management plan to lead to 0 nausea and vomiting, everybody's going to be disappointed. My usual plan for them is to say that I need you to get to a tolerable amount of nausea and vomiting so that you can maintain your nutrition, you can maintain your hydration, and you can get out of bed each morning. And that's a realistic approach for most women with severe MVP or HG.
Hello. Sorry, Dr. Lowe, you just froze there for about 20 seconds. If you wouldn't mind repeating that last line.
Okay. I'll just start at the top of this slide. We're establishing targets for symptom relief and we're making them realistic targets, not 0 nausea and vomiting, tolerable nausea and vomiting, and then still able to maintain oral hydration and some nutrition. I recommend discontinuing prenatal multivitamins, but substituting the 2 critical micronutrients, iodine and folate, much smaller tablet than any of the multivitamins on the market. And without the iron and without the B vitamins, they're much less likely to get nausea. It's really important to time the administration of your antiemetic therapy to the woman's symptom pattern. So if she's a woman that gets most of her symptoms in the late afternoon, you don't need to be giving antiemetics in the morning. The term morning sickness really is a misnomer for most women. The choice of antiemetics should be individualised based on the woman's symptoms, her previous response to treatment. So if you recall my first patient who'd had NVP before, I'd go into what worked for her before. Obviously, metoclopramide's not working, so I'd probably not use that. And I also need to understand how potential side effects might impact on that individual patient. We always commence with oral therapy before parenteral or subcutaneous treatment, which is reserved for refractory cases. This guideline strongly recommends written instructions should be given regarding what therapy, when to take it, what to do if you're getting better, and what to do if you're getting worse. And that's an individual treatment plan which we give to the patients, and we update at each visit. And we review their therapy very regularly, at least once every 2 weeks, if not more regularly. So this is what our recommended treatment plan is. So there's one piece of paper written on 2 sides. One side is where we write our recommendations for the woman. The other side is where she gives us feedback. When they come back to see you, they're already distressed, they've sat in your waiting room. If they've made notes before they come to see you about on these particular parameters, how they're eating and drinking, how their activity levels are going, how they're managing their family, what their mood is, and did they have IV fluids this week and how often. And I've got patients who diligently bring in this feedback every single week, and I've got patients that have never brought it in. But those that want to communicate that way, it can be a really effective tool, and it does give them some control back. And a lot of the distress of NVP and HCG is about losing control for these women at a time when they really want to be feeling happy and positive. So we'll get to the psychosocial support, but of course, encouraging them, telling them that you can help them and meaning it because you know what you're doing, giving them the psychosocial support they need, giving them time off work or reducing their work hours, encouraging them to let their families help. All these things are very important aspects of management as well. But then they get this written plan that tells them what they're taking, when they're taking, and why they're taking it. So they don't stop bits of their treatment as patients, not your patients, but my patients occasionally stop treatment that I've recommended because they don't understand that it's part of a holistic approach to their problem. When they see it written out like this, they understand much better. We also write down what they should do if they're feeling worse between visits and what they should do if they're feeling better so they can down titrate their treatment as well. So this is an example of one of those plans. This is my plan written in Amanda's beautiful writing because mine never looked like this, but it's very specific about what we're giving the patient. So that just gives you an idea how you might use that tool. But you might make your own tool that suits your manner of consulting. What about non-pharmacological treatments? Of course, we have to use those, but we've reviewed the literature on these, and unfortunately, there's no good evidence that any of these things work across the board. But for your patient, rest in the afternoon, if their symptoms are worse at 5 o'clock, might be very important. Diet, the old prescription of you must have small, frequent meals and they must be carbohydrate. My personal experience is let them eat whatever they want, whenever they want, and encourage them to eat whenever they can. So again, the patient who has most of their symptoms in the morning should be encouraged to eat and drink much more in the afternoon and not worry too much about eating in the morning. I've got patients that only want to eat McDonald's and chips. I've got Asian patients that only want to eat their mother's ginger chicken soup. So there's often a cultural aspect to what they desire. So basically whatever they can manage, whenever they can manage. Fortunately, no data supporting the use of acupuncture, acupressure or hypnosis, but I wouldn't discourage it if the patient wants to try it. When we come to pharmacological therapy, it's not just about antiemetics, but it is about a graduated approach to antiemetics depending on the severity of the condition and the patient's response and previous response. We also strongly recommend for people with severe NVP or HG, the addition of acid suppression, laxatives whenever needed. We will talk about steroids, and we'll talk about other treatments and future treatments. So for each of these various therapies, within the guideline, we've got a very detailed chart showing their mechanism of action, some abbreviated evidence for the efficacy, recommended doses and maximum doses, a short summary of side effects, a comment about the risks of teratogenesis, and some practice points. So that will all be in the detailed guideline for you to see. But the overall management, overall management is based on an algorithm, and the algorithm has two parts. One is this first section, which is all about assessment, categorising the women into mild and moderate, and then moving through a management pathway that is both clinical, includes mental health assessment, includes where you're going to manage them and who's going to manage them, and gives you quite a lot of detail about how to proceed. The next part of the algorithm is all about the drugs. And essentially, we recommend that everybody has diet as tolerated, we cease the multivitamins. The next point is very important. If a specific antiemetic has no effect, then discontinue it before starting a second or alternate agent. Don't keep adding therapy if the previous therapy has been effective. If the previous therapy has been partially effective, then you optimize the dose, optimize the timing around their symptoms, and then add additional agents after you've reached a maximum dose of that first agent. Always add laxatives. And then for milder cases, we recommend pyridoxine, ginger, or ginger plus pyridoxine. And we received a question before the webinar about this. There is data that there's efficacy from these agents. For more moderate cases, we go on to the metoclopramide, prochlorperazine, doxylamine, or promethazine, recognising that these are all sedating, particularly the doxylamine and the prochlorperazine. So you'd really like to avoid those during the daytime if at all possible, particularly if the woman has other children at home or is trying to function at work or just to remain active. So that's where ondansetron steps up the hierarchy because of its absence of sedation, despite the problems that we see with it in terms of constipation. We recommend adding acid suppression for the moderate group as well, and we recommend supervision by at least a GP or an obstetrician or a physician if you have one. Once you get to the more severe group, we recommend assessment with electrolytes as we discussed before, and then we start on higher doses of ondansetron, consider nighttime dosing to substitute for ondansetron with one of the sedating agents to minimise your ondansetron dose, and then if they're ineffective, to consider steroids. And we're recommending prednisone 50 milligrams with a rapidly reducing dose. A tip about using steroids, if your patient's not responding after 48 hours, they fall into the 20 to 30% of women who don't respond to steroids, and I would abandon steroids at that point and look for other solutions. They then, both the moderate and severe category, have options of IV fluids. And then once you get to the severe category or those with refractory symptoms, you may have to consider admission to hospital, but only after you've given ambulatory care an appropriate trial, except for that exception group we discussed earlier. So just to talk a little bit about ondansetron, because that does remain controversial despite its B1 listing. It is the most effective antiemetic drug outside of pregnancy, but there is now some genetic testing to suggest that some women will be more responsive to serotonin receptor blockers than other women, but that's not part of standard care at the moment. But it may in the future allow more individualised prescribing. But in women with HG, there are a number of randomised controlled trials showing ondansetron is superior to metoclopramide in reducing vomiting, but interestingly not nausea. And the antiemetic and anti-nauseant effects are equivalent to the sedating antiemetics, but without the sedation. There's a heterogeneous data regarding teratogenic risk, but our conclusion from this guideline is that it can be used in the first trimester. But you may want to review that literature in the full guideline. And certainly its use has increased rapidly in the last 10 to 15 years. I want to speak about steroids briefly. You're aware that although prednisone can cross the placenta, fetal uptake is limited by active retrograde transport by P-glycoprotein and by metabolism by placental 11-beta HSDT. There are 6 randomised controlled trials in NVP and HG, and the only statistically significant result was reduced vomiting compared with other antiemetics in 2 of those trials, especially when it was used less than 10 weeks. But those of us who have experience in this area know that there are responders and there are non-responders. And as I said, if you have a non-responder, just abandon the trial after 2 days. There's a very small amount of gestation-specific data for corticosteroid use during the relevant period of embryogenesis, that is the 5th to the 10th week. And although most teratologists counsel that there is an increased risk of oral clefts, the data remains very conflicted. The most conservative estimates suggest 1 to 2 additional cases per 1,000 treated women. So you may consider withholding until 10 weeks, and that's what we've recommended in this guideline, taking a very conservative approach. But if you have a woman in extremis, I would recommend using steroids even before 10 weeks, having discussed this data with them. They should be considered third-line treatment after other agents. How do you give treatment? Well, oral therapy first, then parenteral or subcutaneous. There are no rectal antiemetics available that we're aware of. Although if you look in MIMS, it appears that you can get rectal stemetil. I spoke to the company again today just to double check. There is no rectal stemetil in Australia anymore. There are a number of agents available in the UK, including doxylamine, I believe, and hopefully they will reach us at some stage. The oral dispersible formulations, for example, ondansetron, aren't actually absorbed sublingually, although they dissolve, and they need to be swallowed like the tablets. And some people like the taste and some people can't stand it. So you may prefer the tablets over the wafers. You have to check that with your patient. There are options for subcutaneous antiemetic management with ondansetron, even metoclopramide, but they've not been shown to be as cost-effective as bringing the women in for intermittent rehydration and hospitalisation as required. I certainly don't have any experience of that, but I'd be interested to hear if any of you do. The next aspect of treatment we need to discuss are potential future drugs. And as I say, in the UK, there are a number of agents, particularly this slow-release combination of doxylamine and pyridoxine, certainly very effective, but also very sedating. There is a transdermal granisetron available in the US. Transdermal clonidine been studied by one group in Italy who claim it's very good, but it's also a sedating antiemetic. Mirtazapine looks like a very interesting agent. As we'll discuss later, depression can be an important part of this condition. So mirtazapine may be an interesting approach to the combination of nausea and vomiting and depression. Gabapentin may have some role, and there's a single randomised trial of diazepam, which essentially anaesthetised the women, and when they were anaesthetised, they didn't suffer with nausea and vomiting, but we don't recommend it. Finally, the aspect that I want to finish up with before Amanda takes over is treatment of gastric dysrhythmia, which is really reflux and constipation. And many women with vomiting in pregnancy experience symptoms of gastroesophageal reflux, and even those who don't experience it are probably having it. Treatment has been just treating the gastroesophageal reflux reduces nausea and improves quality of life. So antacids, histamine 2 antagonists or proton pump inhibitors should be added in a sequential manner, particularly with moderate or severe MVP or HG. And in refractory cases, you could consider investigating for Helicobacter, as eradication has been shown to reduce some of the symptoms. Increasing fibre and fluids is the preferred treatment, but is often not tolerated, so you're often left using high-dose laxatives. I'll often use Caloxyl 120 milligrams BD, Movicol or Clearlax 1 or 2 sachets a day, or sometimes lactulose is better tolerated than Movicol because the large volume of fluid is difficult to tolerate, and one can use rectal treatments as well. So that's really the approach to the medical therapy of NVP and HCG, but of course there's much more to the holistic management.
So we've talked, Professor Lowe has talked about how and when we treat, but one of the hardest, well, probably the hardest or even the easiest decision is made around when and do we admit to hospital. So we know, I think from a sort of clinical perspective, when we see somebody who automatically we know needs to come in, but often it's a lot simpler if there's actually a set of guidelines that we can sort of put ticks in the boxes next to, rather than just relying on our clinical sort of gestalt, yes, the waters, the feeling in the waters. So there are three main factors which predict readmission to hospital. Gestational age less than 9 weeks, or onset of hyperemesis early and severely. The length of hospitalization of being more than 2 days, and then hyperemesis that has been present during a previous pregnancy. We've talked on a number of occasions around the psychological impact of this, and commonly what we see is having had a previous pregnancy complicated by this often leads to quite significant issues around subsequent hyperemesis, and this can lead to higher admission rates. So the series of, or the 3 or 4 points that we, as a guideline team, have recommended for inpatient admission, over and above, well, including what we've talked about before, would be a patient who has a severe electrolyte disturbance, such as a very low potassium, someone who's developed an acute kidney injury in the setting of being profoundly dehydrated related to their nausea and vomiting of pregnancy. And that's often in patients who are, who've already received IV fluids for anti-nausea effects, but still just aren't maintaining their ongoing fluid intake. We've mentioned before those with type 1 diabetes, those who are transplant recipients and need to have their medications continuously administered, or those requiring essential immune suppression, and individuals with poorly controlled epilepsy who may have some issues around coming off their medications. And then the final guidance in terms of managing as an inpatient are those who have associated conditions, for example, hematemesis or an infection related to it, particularly things like urinary tract infection. So once we've admitted them to hospital, we're monitoring them regularly, and then the decision as to when they are appropriate for discharge is once we've stabilized them on their pharmacotherapy. So once they are, they've got an adequate antiemetics on board, their reflux as well managed, their constipation is no longer too much of an issue. However, and of course that they are starting to be able to tolerate both oral nutrition as well as hydration. This is often one of the key contributors to a prolonged admission, is that we need to balance that pharmacotherapy with their actual nutrient intake. And then obviously, particularly if they've been admitted with some associated conditions, management of those concurrently needs to be complete. And as we've mentioned before, this is another opportunity for us to clearly document the ongoing management plan. So how regularly we're going to see the patient, what they clearly outline on their patient management plan, what are their medications, what to do if things get worse, what to do if things get better, and then ongoing close follow-up and management of those patients. So we move on to a sort of endocrine type part of hyperemesis and nausea and vomiting of pregnancy, and that's this concept of gestational hyperthyroxanemia. So we mentioned very early on that we don't recommend measuring thyroid function tests, particularly in this group of women, and you'll see on our next slide there are some cases in which we do recommend this. We know that the gestational hyperthyroxanemia is a sort of transient biochemical thyrotoxicosis that occurs in a small number of pregnancies, but interestingly occurs in a much larger number of pregnancies complicated by NVP and HG. It typically develops early in the first trimester and is usually gone by 20 weeks of gestation. And the reason that this occurs, and you can see just in the figure on the right-hand side, you can see that in association with a rise of the placental HCG, you have an associated drop in TSH. This is because placental HCG is structurally similar, or has a structurally similar subunit to TSH, and it actually stimulates the TSH receptors at the level of the thyroid and stimulates thyroid hormone release. That then suppresses your endogenous TSH production, leading to this biochemical thyrotoxicosis. Now, typically this is asymptomatic. Patients tend not to have any overt clinical signs, and by definition, they have to be TRAB negative. But as I alluded to before, approximately 30%, so between 30 and 75% of all cases of HG are associated with gestational hypothyroidism. And there have been a number of ideas postulated as to what this might relate to. Is it a higher circulating level of placental HCG? Possibly or probably unlikely, although we know that nausea and vomiting symptoms can be associated or are worse with twin pregnancies. But it seems more likely that there is an altered form of HCG with a higher potency at the level of the receptor, or that the receptors themselves are hypersensitive and are therefore more easily stimulated by HCG. So there's disagreement about which women should have thyroid function tests, and we mentioned this previously. And so we've specifically dealt with this in the guideline. So should it be all women with hyperemesis gravidarum? Should we measure just the TSH, or do we do a full thyroid profile? And do we only test them if they've actually got clinical features of overt hypothyroidism? So we've clearly stated that if it's just NVP, there's no utility of monitoring the thyroid function tests. However, if you've got hyperemesis gravidarum or NVP, which is refractory to treatment, it's reasonable to measure the TSH initially, because we know the TSH is very sensitive, and if there's an abnormality in that TSH, to go on and evaluate further. So what you're looking for are the other more common causes of hypothyroidism, and distinguishing gestational hypothyroidism with this. And so the tests that you might look at are further, or looking at the TSH receptor antibodies and the other thyroid autoantibodies, and if there's a clinical sign of any goiter or clinically significant nodule, to go on and look at a thyroid ultrasound. Now that takes us down an investigative pathway, looking at whether or not there's an alternative thyroid-related cause of the hypothyroxanemia. And the key to that is that that gestational hypothyroxanemia associated with NVP or HG is simply supportive management. So there's nothing further that we need to do, as typically this is all self-limiting and does not directly impact on either the maternal, the pregnancy, or the fetal outcomes. So the question then remains, what impact does nausea and vomiting and hyperemesis gravidarum have in and of itself on pregnancy outcomes? And we really actually have to distinguish between the two when we look at these. So it's always good to know, and I think the first point on the slide is important, that with improved access to both parenteral and enteral nutrition, we haven't touched on enteral nutrition, but it is discussed in the guideline, but with improved access, pleasingly, maternal mortality in the setting of hyperemesis gravidarum is rare. Only 6 internationally reported deaths between the period of 2012 to 2016. But this is not a completely benign condition. So HG really is associated with some other very rare sequelae, including Wernicke's encephalopathy. And we should thank the Hyderabad group from India who sent us their case series of patients who had hyperemesis and Wernicke's, quite scary and poor outcomes in those settings. It's also associated with bleeding diatheses in the setting of a vitamin K deficiency. We've mentioned the acute kidney injury as a reason for admission into hospital, esophageal rupture and sometimes associated pneumomediastinum and surgical emphysema, and there have been incidences of rhabdomyolysis. So what is even more significant, and sometimes I think really is what leaves the women with long-term huge impacts on their psychosocial status, is the significant personal and economic impacts on the woman's emotional and psychological well-being. And I should say not only the woman, also her family members too. And it's something that we can't underestimate, and we should talk about more clearly. So in terms of the immediate postpartum and future maternal health, there's certainly, when we're looking at outcomes, both pregnancy, maternal and fetal related outcomes, there's not a lot of data. There are a number of observational studies, some cohort studies, and one or two meta-analyses of studies that have been done. But in terms of postpartum and future maternal health, there's a single study that really looked at these significantly elevated levels of post-traumatic stress in women who'd had hyperemesis, their difficulty breastfeeding. And if we think back to Mrs. JC, our patient who we spoke about in the first slide, following her first pregnancy, she experienced difficulty with breastfeeding, marital problems, financial problems, and the inability to self-care really have a profound impact on future maternal health. There's also an interesting association with a slightly increased risk of breast cancer. And the etiology of this is not clear. It's difficult to, it seems to be more an association than a direct causative risk, but there have been two studies, one a prospective cohort study and one a single case control study, which showed slightly higher risk of breast cancer in subsequent to pregnancies complicated by hyperemesis gravidarum. So that's the maternal health. What about the neonatal outcomes? Now this is it's very clear that neonatal outcomes depends on whether you have NVP versus whether you have hyperemesis gravidarum. So one systematic review demonstrated a lower rate of miscarriage, congenital malformation, prematurity, and childhood IQ. A second study, a large Norwegian mother and child cohort, demonstrated both positive and negative aspects. So from the positive aspects, they had a lower incidence of preterm birth, lower incidence of cesarean section, lower incidence of low birth weight or small for gestational age babies, and a lower risk of poor APGAR scores. However, those pregnancies seem to demonstrate a slightly higher odds risk of having pelvic girdle pain, having proteinuria, borderline hypertension, and preeclampsia. Although I should just clarify that in this study, the majority of these women, certainly it was statistically significant, that the larger number of these women actually had had previous pregnancies that were also complicated by a number of these, particularly hypertension and proteinuria. So although there's a number of studies which suggest that there's no increased risk of low birth weight or small for gestational age, that's not borne out on every study, with another recent cohort study suggesting untreated NVP may be associated with a lower birth rate. But certainly when it comes to hyperemesis gravidarum, there's definitely an association with placental dysfunction, with a 2011 meta-analysis and systematic review suggesting that women who'd had pregnancies complicated by HG had a higher risk of having a low birth weight baby, a small for gestational age baby, or a preterm delivery. And you can see the forest plots just there on your right. In addition to that, further sort of touching on that placental dysfunction, there was a doubling of the risk of preeclampsia, 3 times the risk of placental abruption, and increased risk of an SGA newborn. With that same study demonstrating that when you look at the long-term follow-up, and this was only limited to a short period of time, and not all the patients involved in the original studies, but the small amount of long-term follow-up suggests that there may be a slight increased risk of insulin sensitivity, lower verbal performance, and full-scale IQ. And the predictors of these were related to the severity of hyperemesis with a prolonged hospitalization, but also, once again, rearing its head, this concept of the maternal mental health response with higher levels of maternal depression. So what is the recurrence risk of NVP and HG? Well, nausea and vomiting of pregnancy is incredibly common, the recurrence risk up to 85%. But in hyperemesis, things are if you've had previous HG, but if you haven't had a pregnancy complicated by it, only 0.7%. There was another English study which demonstrated 26% of those having been hospitalized and hospitalized in the previous pregnancy, subsequently developing HG. And of probably the most concern to me, and really important in terms of why we need to identify this early, treat it well, support our women from both a physical and an emotional aspect, is that one hyperemesis questionnaire suggested that 37% of women who'd had a previous pregnancy complicated by HG decided not to have a future pregnancy. So that's over a third of women. So I've highlighted in green because I always bang on my preconception counselling drum, but it really is absolutely essential not only to address any mental health issues, any post-traumatic stress around previous pregnancies, but also to identify an early management strategy so women come in as soon as these symptoms may begin in future pregnancies in order to address them early, begin treatment early, and that way hopefully prevent an escalation in their symptoms and a requirement of admission to hospital. So just as we finish up with our last few minutes, what we also have included in our SOMAN's guideline is some patient information, and I've just popped them up here on the slides. What is hyperemesis? Does sickness and vomiting affect the baby? Do I need any special tests? And these all come off the back of some sort of focus groups that were done, sort of social media focus groups about what women wanted to know. And so they are well tried and tested, and the language is simple and easy to understand. And it's something that we think more and more information, plus the pregnancy sickness plan, hopefully will support our women as much as we possibly can. Okay.
So the complete guideline has 200 and something or other, 270 references, and is a very, very well-referenced document and will be available on the website once we confirm publication. There is also an executive summary that I think you'll find quite helpful because it's a more concise version of the guideline, but it also includes a number of other aspects. It has specific recommendations about what should be done and what shouldn't be done. It stresses the practice points, and it also recommends a variety of audit opportunities that will allow you to determine if your practice is meeting the needs of your women. So it may be how many days, hospital days are spent on women with hyperemesis. It may be how many women complete a individualized patient plan, how many admissions to the emergency room occur after you've implemented your pathway compared to before. So we'd strongly recommend you look at those audit opportunities and select those that are...
Sorry. There we go. Sorry, Mum.
Oh, she could have joined in.
She could have joined in.
So the executive summary has some slightly different aspects in it, particularly these audited opportunities. And when we publish, we've written in October an edition of Anne's Job. We haven't had that accepted yet, but we hope to do a more concise version of the guideline for publication as required by that particular journal. And before we finish our part of the presentation, and hopefully we'll hear from you with some questions.
Got a question up here.
I'd like to thank the other members of the writing committee. So Amanda is one of those members, but Georgina Armstrong, one of our registrars, Lucy Boyer, a maternal fetal medicine specialist, Luke Greskoviak, who's a clinical pharmacologist with an interest in pregnancy from South Australia, Catherine Marnock from New Zealand, and Helen Robertson from Brisbane. So I'd like to thank all those people who were assisted in the development of this guideline.
Now we do have, well, we've got at least one question. So the first question is it necessary to start thiamine to all pregnant women with hyperemesis?
If you look on slide 19, we'll go back to the algorithm. You'll see that we recommend thiamine in those women whose intake is poor. So if you, where is it? There it is. Add IV thiamine on both the severe group and the moderate group if intake is poor. But if the women are eating and drinking, particularly if they are still managing a multivitamin, they don't need additional thiamine. Obviously, all the usual precautions to avoid Wernicke's of not giving dextrose without thiamine, and our IV fluid protocol, which there's a specific protocol, does not recommend dextrose. It actually recommends saline.
It does, that's
saline
right.
or Hartmann's.
So thank you, Wendy, who says thank you to us. Any other questions out there? You can type them to us in the webinar chat, or you can put them in the Q&A. I have one question that came up earlier, which we had a discussion about, but I think is interesting for those of you who are online. So what about women who have underlying eating disorders? Where do we go with them? Because this is obviously quite a tough group of women, a very challenging group of women with multiple issues.
When we were discussing multidisciplinary care earlier, we included GPs, emergency physicians, obstetricians, pharmacists, but dietitians certainly have a role in that group of women. So. I think they shouldn't be treated as hyperemesis. Yep. If it's clear that there is an underlying eating disorder, you will overtreat them, you will exacerbate their already marked gastric dysrhythmia. And I think they're a really difficult group. I think you need a psychiatric and psychological input by professionals, dietitian, all the resources you can bring to bear, but I don't think they're going to respond to the treatments for hyperemesis. I think you're going to be very frustrated. And as we know, these women are their own worst enemies. It's really a very, very difficult situation. So the answer is I've done preconceptual counselling for women with significant eating disorders, and I've recommended against pregnancy for a number of reasons, irrespective of the fertility and pregnancy complications they experience. They are going to struggle. They're going to struggle in pregnancy to maintain nutrition.
So we have another question. Is there any recommendation for vitamin K replacement if the INR is elevated with normal, I think that must be clotting time, suggesting vitamin K deficiency?
It would really depend on, I'll let you answer that. I think it really depends on the nutrition. You'll have if you're seeing these patients regularly, you'll have a sense of what they're eating and what they're drinking. You can certainly do their clotting factors if you're suspicious and replace vitamin K. I think broadly speaking, if you treat these people properly at the beginning of pregnancy, you are not looking at vitamin K deficiency at the end of pregnancy. I'd like to go back to Mrs. JC because she's a real patient of mine. I took one liberty. She's actually not G2P1. She's G4P3 and required a reversal of her husband's vasectomy to get pregnant. But she was so traumatized by her HG last time, she almost needed another pregnancy to get over it. It was the most unusual situation. But she's now 15 weeks. This is the first pregnancy where I've treated her. She's extremely responsive to steroids. She's returned to work part-time. She's been able to look after her children. And to link it in with your question, I'm no longer worried about that woman having nutritional deficiencies because she's been properly treated. It's the untreated woman or the woman who's been poorly treated that's going to get vitamin deficiencies.
Yeah. So certainly that links to treating them early, getting the right treatment, not just weeks and weeks of one ondansetron, one Maxilon not working, getting on top of it early.
I think if you're in a setting and you don't have a lot of experience, once your patient is no longer able to eat and drink, or they're required admission to hospital, they need specialist intervention. And I may be biased on this, but I've got ongoing treatment of people with hyperemesis every single week. If you're an obstetrician, you might treat one a year with the sort of incidents that we see. Or if you're an emergency physician, might treat a lot of them, but really badly, really badly every week.
Yeah.
So I think they're important. They're really important issues. Can we hear about your experiences of hyperemesis? Is it something that you see? Do you feel confident? Do you think this guideline would be helpful for you? We have a hematologist's response to this question who says that they're unlikely to get vitamin K deficient, but if the INR was elevated, there'd be no harm in trialling some vitamin K. Thank you, Natalie.
Just a friendly reminder, if you can still submit questions through the question pane or the chat function. We'll just wait a couple minutes so they come through. Dr. Lowe and Dr. Beech, we've got a few. Thank you to both for a super interesting and I guess presentation and raising my awareness of the new guidelines. Fabulous webinar, top job.
Thank you.
Can I just say something about the recurrence issue that I hadn't thought about before? The recurrence issue is severely impacted by the number of people that don't go on to have another pregnancy. So the recurrence risk that we give of 15%, I never give 15%, I always give them 80%, and that's my experience. And a lot of that data is coming from blogs now, women getting together. There are a lot of blogs out there on hyperemesis with really miserable names about throwing up. But these women are finding each other and they are seeking expertise. So if you have expertise, promote yourself because these women need you in wherever you are.
Thank you.
Take me and my cold home. Excuse me for that.
We've just got a yes, this guideline will be helpful, and we do see a fair number of such patients from Talat.
Thank you.
That's great. Well, hopefully you'll find it nice and simple to use.
We'll do a plug for the Samans meeting in October where we'll be talking about this, and also at RANSCOG I'll be speaking on the same topic. Thank you.